of picked up on this. Mitral patients sometimes struggle a lot in the ICU with finding those. Why? Okay, so 2 reasons. One is if you have mitral regurg, the blood goes backwards to the left atrium and can go out to the aorta. So it's got 2 routes of escape, right? So the LV kind of can get lazy and not be used to having to push all that blood out to the aorta, part of it left to the left atrium, right? So then you fix the mitral valve, and now it has to push all that blood forward instead of some of it passively going backwards. So the LV may be not trained to do that. It's like if you told someone to get off the couch after 6 years of hypertension and run a marathon. So some hearts are quite ready to do that on their own. The other thing is, depending on what we do in the operating room, the aortic valve you can think of as just valve leaflets in general. The mitral valve is more complicated. There's leaflets, there's cords, there's papillary muscle, there's annulus, there's the LV. Okay, so it's very much integrated in the LV. In the old days, when they replaced the mitral valve, they would cut out the cords, put the valve in, and expect these leaflets and the heart to work the same as it did. Well, when you cut the cords, this is that weird picture. When you cut the cords, the heart loses its shape, its natural shape, which is an elliptical shape, and it kind of dilates out like this. And so you don't have that attachment up there anymore. And so the heart doesn't work as well. It's not designed to be like that. So this is a study that showed the pinkier the people that they save the cords, and the ejection fraction really didn't change much. The blue lines are the ones where they cut the cords, so the ejection fraction drops a lot because the heart now, it's not really designed to be that molecular shape. Okay. Anything else? Yes.
I don't see that we use albumin a lot if somebody is hypovolemic. You know, if what's the rationale, or am I wrong, or
No, I think it's just surgeon preference. There's not necessarily good evidence of that. Some places use albumin. It can, I think it does tend to leak back into the third space more, and then so you can have more fluid flow pulmonary defect that you have to get rid of. So that's it. I would say that's why I do it. I don't think there's any randomized studies between versus other.
Why do we use fentanyl as our main IV pain medication of choice, just with a short half-life? I guess I feel like it's just a lot of times you're reaching that hour and you're still needing more pain medication with fentanyl. Is there a certain rationale with fentanyl versus other pain medication, or is it just short half-life?
Not really. Again, I think just sort of preference. I think it is a little bit better in the elderly. I think, in my experience, I don't know if you guys have this, morphine seems to work better in young people, fentanyl better in older people, and do tend to have older people. I think also the short half-life, because you worry sometimes about the effects on the blood pressure. Anything else? Okay. Thank you.
Thank you so much.
Email me or call me if you have questions.
There's clap.